All right. Hello, everyone. Welcome back to another episode of CRNA School Prep Academy podcast. I'm your host, Jenny Fennell. And today we're going to talk about emergence from anesthesia. So in the previous two episodes, I covered induction and maintenance. So if you have not listened to those episodes, I encourage you to do so. So today we're just going to talk about, everything that has to do with emerging from anesthesia and maybe the different forms, different maybe possibilities of things that could arise during this time. So I'll never forget when I was in my training, they kind of compared the induction and emergence to anesthesia, kind of like taking off and landing of an airplane. And so like when you take off, when you're in an airplane and when you land in an airplane, those are the riskiest parts actually of flying. And I know that resonated with me because I have a huge fear of flying. I just hate it. Like the physics behind it, like blow my mind. And I just don't understand how a heavy airplane can fly through the sky. It freaks me out to say the least. And so when I heard that, I was like, oh gosh, like every time we take off and land, I'm nervous, but kind of similar to anesthesia, those are typically if you're going to have a problem, that's typically when things arise. And don't get me wrong, during the actual maintenance phase, something could happen in the actual surgery that you weren't expecting that could cause kind of a shift in the plan. But kind of similar, once you're up in the sky, usually, you're usually okay. You're usually good to go. So induction, the reason why a lot of things tend to happen with induction is because you don't know, maybe there's an allergic reaction to something. Maybe the patient ends up, the blood pressure is really sensitive. Maybe they're super dehydrated. So they don't, they tank their blood pressure, or maybe they have a difficult airway. There's those types of unknowns with the induction. With emergence, it's not that at this point, you already know about your airway. You already know you didn't have any allergic reactions. You've already been able to stabilize their blood pressure, at least hopefully, during the case. But however, like that being said, let's just say you struggle with the blood pressure. Maybe there's a reason behind it, depending on what the case was. Maybe you ended up starting some levofed, okay, or some like a neo drip during the case. Ideally, you don't really want to take a patient over to PACU on well, definitely not levofed, but like, the neo drip or whatever. You want to make sure the patient is essentially back to their baseline prior to taking them over to PACU. Okay. And that means respiratory as well. Now don't get me wrong, baseline, like, obviously they're going to have some narcotic on board, but I mean like stable and being able to maintain their own airway, oxygenating okay, exchanging. You obviously want them to be comfortable. So they may be a little sleepier, but their airway is going to be maintained. And so when you're planning for your emergence, you want to be assessing all these things. And really one of the key things is, well, one, you got to know what the case is and how painful the case is, but you also have to clearly be watching your patient and listening to your patient. Someone who routinely takes oxycodone for low back pain, but they're having, maybe, a colostomy placed, they're going to have a lot different tolerance to your pain medicine than someone who's narcotic naive. Okay. And so you really want to be taking that consideration. Some patients are on chronic fentanyl patches. Okay. And then do they currently have a fentanyl patch on? When was their last dose at home? You have to be kind of thinking about these things prior to even doing the anesthetic. And especially during your maintenance your emergence, you want to be making sure that you didn't get behind on their pain control. You want to make sure that they're optimized. And really the best way to do this, you guys, is to try to get them back spontaneously breathing. You want to try to assess their vital signs. Where did they come in at? Was their blood pressure 120 before they went to sleep? And now their blood pressure is 160. Well, why is that? Are they also tachycardic? What else is going on with them that could potentially cause them that high blood pressure? Is it maybe they got too much fluid during the case, or I don't know. You have to, again, do your best assessment and try to figure out what is the cause based on what you're seeing on the screen. But really the respiratory rate is really a really good indication of knowing how comfortable your patient is going to be. If they're exchanging to the point where their end tidal CO2 is 32, they're probably going to be in pain. If they're breathing fast enough to get their end tidal down to 32 on the ventilator, with just say maybe a pressure support of 8, they probably need more narcotic. So again, assessing how fast are they breathing, what's normal for them based on their age, based on their pathophysiology process. If you have someone who is a respiratory cripple, who maybe lives with a CO2 in the 50s, well, is there CO2, where's their CO2 currently? And also you want to keep in mind, what's a safe CO2 to wake someone up on? Is a CO2 of 80 okay? No, it's not okay. So, but if their baseline's in the 50s, is it unrealistic to think that they're going to be in the 40s? Yeah, it's unrealistic. Okay. So again, you want to make sure that you're taking that consideration when you're waking someone up. And being careful too, because again, someone like for example, who's a respiratory cripple, let's just say they look okay on a little bit of pressure support, but maybe they're still weak from some of the muscle, from some of the paralytic you gave. And maybe they haven't been adequately reversed from that. And now maybe they might look okay, but as soon as you get them extubated, they're going to look weak and eventually they're going to build up. And so you want to make sure that, again, you're fully reversing these patients who are at high risk for respiratory complications. If there's any point in the case where you feel like maybe they had some atelectasis going on, which almost all patients do during anesthesia, because you're essentially taking away their ability to breathe and maintain that environment in their lungs, you're essentially putting an airway down their windpipe and creating an atmosphere where they're going to have total collapse of their lungs. So patients do get atelectasis during anesthesia. So it's important to do some recruiting removers. And the best way to do that is to take your pop-off valve. It's called your APL valve, and you would turn that to 30. And then you just simply hold the bag. You don't squeeze and squeeze and squeeze. You want to actually just hold some firm pressure. And if they're breathing through that, you can kind of go with them a little bit, but you want to maintain that positive pressure that's really going to help recruit the lungs and pop the alveoli open. And what's really cool is if you get to do lung surgery, you'll actually see this happen. It's really fun to watch. So that's kind of how you re-recruit. You can do that anytime during the case. My only thing I want you to be aware of when you're doing that is keep in mind, when you're putting that kind of pressure in someone's closed cavity in their chest, you're also going to be decreasing their their preload. Okay. Because now you have an increased thoracic pressure. And if they're already dehydrated, well, now you're going to tank their blood pressure. I've seen patients vagal with that. Okay. So you got to be aware that doing that is not necessarily a benign maneuver either. You have to be aware of what the patient's blood pressure is, and obviously watch out for vagaling because it can happen. So those are some things to think about when you're doing the recruiting measures. But again, you want to optimize someone for wake up. Do they need a pulmonary toilet? Some patients do. If a patient has some kind of physiology process to where maybe they have, a history of mucus plugs, or maybe give them a good pulmonary toilet before you extubate. And all that means, you guys, is lavaging a little bit of sterile saline down their endotracheal tube and just suctioning them out really aggressively, kind of like a bronchial lavage. I mean, you've probably done it in the ICU to collect sputum samples. So it's essentially the same thing. You're just doing it before you extubate someone under anesthesia. Obviously suctioning, making sure that you're getting them really good, whatever is down there. You want to make sure you're really breaking it up prior to extubating them to give them the best shot of being okay after the tube is removed. One thing that I was kind of nervous about when I first saw one of my coworkers do it, they're like, oh no, watch this. This is how you know for sure they're going to be okay to be extubated. And it's funny, working in adults, I actually never saw this done. And it just goes to show that you can pick up new things from different facilities, which is why I think it's very awesome to travel to different facilities as a student, because you're going to see different techniques, different ways. And some of them are going to be really awesome. Some of them maybe you won't like as much, but hey, that's the part of learning and that's your choice to make. So when you're done with school, you can kind of do what you think is best. Anyhow, this was the takeaway for me, that I was kind of, so it was a child, and I don't remember how old. I want to say like less than a year old. I want to say like right around there. They just disconnected them from the vent when we were emerging. Completely just took the ventilator off. Like we were just on some pressure support, for example, breathing spontaneous. Took it off, and then we would let them breathe with an endotracheal tube in, and like just to see if he would maintain his O2 saturation. And I was like I didn't at first. I was like, really? Like I've never seen anyone do this before. They maintain their O2 saturation. So they're like, yeah, no, you'll know they'll be good if you know that they can do that, as far as maintaining their O2 saturation. So I thought that was kind of a unique, different way of like testing, because especially if you can overcome the resistance of breathing through a straw, like if you're going to be good enough to breathe through that straw and not drop your O2 saturation, you're not weak from your paralytic. You're obviously able to overcome that and compensate. So, not that, maybe don't try that without talking to your preceptor first, but it's just something to keep in the back of your mind, that is, if you're ever questioning how they're going to do, try it, see how they do on room air. And I mean, technically that did probably create atelectasis. So obviously recruitment measures again, you can also probably just put them on room air on the vent and just see if they maintain. But, you know, people kind of get tricked, I think, a little bit, you know, especially if you have higher pressure support, like maybe you're on a pressure support of 14, you really need to be on a pressure support of an 8, essentially, to kind of have a gist of how they're going to do off the vent. If you're on higher pressure support, even if you're spontaneous and you're breathing well, you need to really lower that pressure support to really get a better feel for how they're actually going to be able to, what kind of tidal volumes they're going to pull on their own. So keep that in mind. Obviously, you want them to be completely spontaneous on the ventilator prior to removing the endotracheal tube. I'm not saying to extubate someone on pressure support at all, but I just think when you're kind of in the middle of waking someone up and you're making that move to spontaneous breathing and you're putting them on pressure support first before you put them totally spontaneous, it's kind of make sure you're weaning that pressure support down, okay, and then flip to spontaneous and see how they do, okay? And keep in mind, if they're still on 100% oxygen, well, how are they going to look on less than that? You know, so that's why I'm trying to explain this technique. So you guys are not, I'm trying to give you context around why we did it, okay? Because a lot of times you're waking patients up on 100% oxygen, but how are they going to do on room air? You know, and then, you know, that's one thing too, is always have a plan in mind. Well, are they going to need oxygen for PACU? Okay. Because on 60% O2 or on 100% O2, they're only satting 96%. Why is that? Are they weak from paralytic? Do they have atelectasis? You really need to try to troubleshoot that a little bit, because ideally you want to try to make it so they don't need oxygen, especially if they came to you not on oxygen, you know? So I encourage you to try to take that approach. That was also something new to me as well. Like almost everyone, regardless, I feel like we extubated and went straight to O2, like nasal cannula, mask, whatever. And then where I went to different places, like a surgery center and now pediatric, and we just rarely ever use oxygen to transport to PACU. Essentially, you need to be optimizing them so you don't need oxygen. And don't get me wrong, some people just do, and that's okay. And that's completely okay. However, your goal with waking someone up is really to get them back to where they don't necessarily need that. Now, it doesn't mean it's wrong just throwing on them just in case. No, it's not. But I'm just sharing my experience from different places. Some places is pretty routine, always have a nasal cannula on the patient when taking the PACU. Some places routinely don't do that. Okay. And they only put a nasal cannula on a patient to PACU if they need it, or a face mask or whatever it is. And so just don't be surprised, because you're going to see a variation in that where you're like, really, we're not taking oxygen to PACU? Who does that? I mean, some places don't. So, yeah, I don't know. I just wanted to throw it out there. But if you think about the rationale behind that, it's really because you really should be optimizing them so they don't need it. Okay. So keep that in mind when you're waking them up. Really kind of the two things, you guys, that are really going to hose you the most when it comes to waking a patient up and needing, you know, and not having it go smoothly is residual paralytic and essentially narcotic and anesthetic gas. I guess that's three things. Anesthetic gas, narcotic, and paralytic are really the three things that are really going to like mess with your wake up or your emergence per se. A common mistake that students make early on, myself included, was one time it really burned me bad. I don't know if I have time to get in that story. Maybe I should, just for fun, but essentially I was a new student, probably 2 months into my OR. And now, mind you, I was in an integrated program. So we started clinical very quickly. Like I started the program, I think in June, and by September, I was in clinical like 2 or 3 days a week. This happened, I think, in October. So I had barely been in clinical for that long. And the patient was lateral. I don't even remember what we were doing, but she had like 0.4, teetering between 0.4-ish or so of gas. Maybe occasionally dropping to 0.3, but going back up, whatever. So I started talking to the patient. I started saying, "You're waking up, you're all done," you know, and long story, kind of cut to the chase. My who I was with in the case was not with me at the time. It was someone filling in. They were more interested in talking to the circulator nurse across the room. I was by myself with the patient, like I said, and they heard me saying, "You're all done, you're just waking up." And they said, "Okay, we'll go ahead and pull the tube." And I'm like, no, they're not ready yet. And then they're like, "Pull the tube." And I'm like, no, they're not ready. I'm just talking to them. They're like, "Pull the tube, pull the tube, pull the tube." I mean, just started screaming. And I was just like, boo, like what, like, I don't want to not listen to, you know, someone who essentially is ahead of me, someone who is there to give me support, but yet they haven't come over here and laid eyes on my patient, and they don't know what I see because they're across the room talking to the circulator. Now, obviously, being where I am now in my career, I would have been like, "Get your butt over here and you can pull that tube if you think they're ready. They're not ready. Like I wouldn't have ever questioned how to handle that situation. However, as a brand new student, I was intimidated. I was like shy. I was like, I can't believe they're yelling at me about this. And so long story short, we pulled the tube and it was too soon and we dealt with a laryngospasm. And so why I'm telling you guys this background story is because, again, gas can get you in the wake up and stuff like that can happen. If you pull that tube during that stage 2, where they're a little more irritable. And also another key thing to make note of is you will see a spike in heart rate when they actually go into stage 2. So sometimes like you'll be like, I think they're in stage 2. They're bouncing around right around a 0.3, 0.2, 0.3-ish end-tidal gas of whatever kind. And 0.3 is MAC awake is technically, but again, all patients are a little different. But maybe you haven't seen a spike in heart rate. Maybe they're just like breathing spontaneous. Here's some things you can do to see how close they are to stage 2. This will usually bring them into stage 2. There's a couple of different ways to do it, but it's just stimulation. Okay. It's that simple. Give them a painful jaw thrust. Put your finger behind their jaw and push and dig in and push because it hurts. Okay. You're causing pain. Now, if they hold their breath, if they get tachycardic, if that means they're in that excitable phase, it'll kind of get them into that stage 2 just from that stimulation. Okay. But typically you'll see a spike in heart rate, and the respirers, if you're really in stage 2, you're going to have your irregular respirations. Really, when you know someone's through stage 2, again, you're not going to have deviated pupils, meaning you open their eyes and see if their eyes are looking straight or are they look 2 different directions. If they're in 2 different directions, they're still too deep. They're right in stage 2. Okay. Also, again, if they're breath holding with stimulation, stage 2. If they went from being normal heart rate to all of a sudden tachycardic, more than likely they're going into either a couple of things. They could be in stage 2, or they could just be getting light enough to actually wake up. And again, that's why you're also assessing all these things. You're not just going based on heart rate. You're not just going based on breath holding. You're literally looking at the whole picture. And also a simple thing too is, can they respond to their name? Meaning, hey, Susie, you're all done. Open your eyes. If they try to open their eyes, they're light enough to say, I'm done. Like then typically it's, if they can follow commands to like open your eyes, take a deep breath, you're going to be fine. that tube should come out. Okay. It's harder in a patient that maybe can't communicate with you, like in kids, or even in an adult that doesn't speak English, or, I mean, whatever the case is, it's harder to actually judge that with that type of a wake up when you don't have someone who can truly understand what you're asking them to do. And that's when you really rely on your other physical symptoms and signs of being ready. Always keeping in mind that if you were to pull it too soon and have a laryngospasm, what would you do? Okay. So positive pressure. I've had some, you'll read and learn about lidocaine 100 IV. I personally have never seen that work. But there are probably some who would say that try it, but propofol for me is way better than lidocaine. I mean, if you give them propofol, chances are you could get them a little bit deeper. Again, don't slug them like an induction dose, like I would say like a standard size adult, 30, 50 milligrams would be plenty. Obviously with a kid, obviously then you start going to weight-based dosing. But again, getting them a little bit deeper again is a good way to kind of, especially if it's not a complete laryngospasm. And also that's another thing too, is you need to make sure, is this a complete laryngospasm or is this a partial laryngospasm? Partial, you're going to hear the cooing. You're actually going to be moving air. And so that's a good thing. When you hear it, that's a good thing because that's a partial, meaning it's going to be easier to break. And you don't have high risk for the flash pulmonary edema that you do with a complete laryngospasm. Now, if you get a laryngospasm and it's complete, what's tricky about this, you guys, is it's really hard to tell sometimes because you're just not going to hear anything. You're thinking, oh, they're fine. They're breathing. No. You keep your eyes on that patient. You watch for fogging in that mask. You look at their collarbone. And again, for those of you who are watching on YouTube, I'll show you what it looks like. Like you see that? You see how I sucked really hard? And you can see my right below where my, I don't know, what do you call it? Not xiphoid process, right above my xiphoid process. Anyways, you'll see kind of an indent in my neck. That's because I'm sucking hard. And so when your cords are closed, you're going to see that. Okay. And so you got to watch for that. When you have someone who has a complete laryngospasm, you really have to then follow up with them in the PACU to make sure they don't get negative pulmonary edema. It can happen. I have seen it happen. Typically the more muscular, robust person that happens to, the worse it could be. If it's a frail little old lady, probably not as big of a deal. If it's a young, healthy 30-year-old, they could probably inspire hard enough to cause pulmonary edema. Then also, how healthy is their heart? If they already have underlying heart condition, it probably wouldn't take much to put them into that pulmonary edema type situation of congestive heart failure. So those are patients who are a higher risk. Now, you're probably freaking out. You're like, oh my God, Jenny, I don't ever want to wake a patient up. Like, I'm terrified. It's okay. It doesn't happen that often, but you have to be aware when it does happen, whether it's complete or partial, and what do you do? Okay. Obviously, if it's partial, the propofol, get them deeper, positive pressure, put your pop-off valve to 20 centimeters of water, hold that positive pressure while they breathe and really help them breathe through it. You'll actually start hearing, and then, don't be afraid to turn your gas on too. Just deepen them up. As long as you keep them spontaneously breathing, use your gas, get them deep. That's going to be the best way. Obviously, succinylcholine is the drug of choice to break a laryngospasm. Okay. Typically an adult over 50 kilos, you would just give 20 milligrams. Okay. But obviously with kids, you have to then go to refer to your weight-based dosing for the laryngospasm. Okay. And that's usually 1 to 2 milligrams per kilo. Okay. I would say opt on the side of 1, okay, per kilo for that. But again, you want to do the positive pressure, get them deep. If it's a complete laryngospasm, I would have a lot less threshold as far as giving succinylcholine, because again, you're risking the pulmonary edema. And so, if you don't hear any air movement, you're seeing the sternal notch like being sucked in. At that point, you've given propofol, nothing's happening, then get your sucks and give it. Okay. You need to be breaking that spasm. Okay. Quickly, sooner than later. Here's where sometimes people can run into trouble with that. Maybe the sucks is not drawn up. Maybe it's on the back stand and you're not in arm's reach. Okay. So, and if you're by yourself, okay. And, now, first of all, you should really always have sucks within arm's reach. You should be putting it on your anesthesia machine at the top so you can easily reach it. If you're really worried about it, you should already have it drawn up. Okay. And so I'm speaking from both worlds because I've had experience in both adult hospitals, surgery center, and pediatric. A lot of hospitals now are actually pre-drawing sucks up in a pre-filled syringe, which is really nice. However, you're not always going to have that. And so there'd be a lot of times where, and again, this is something that was routinely practiced in adults, is you would have a syringe labeled with a vial and you would just have it ready to go. So you weren't cracking the vial, okay, and wasting it. Because if you're only going to have it as an emergency drug, does it really make sense to draw it up every single time and just throw it away at the end of the day? To be honest with you, it probably does, because it can be a life-saving drug. However, routinely, this is what people would do. They would label a syringe, have it on your anesthesia machine, and you would crack it as you need it. The problem with that is, especially if you're by yourself, you're going to have to physically drop your hands to do that, draw it up, and then give it. Now, obviously you would do that if you needed to. The other situation I have been in where I actually utilized my resources in my operating room was, of course, it was me giving a lunch break. Stuff always happens on lunch breaks, but either way, I gave my girlfriend a lunch break and they turned the bed 90 degrees. Well, after they turned the bed 90 degrees, the surgeon extubated my patient by mistake, obviously. And then the patient spasmed. And then of course I was trying to turn the bed back so I could reach him again. Patient was laryngospasming, and the sucks was, again, the syringe was labeled, but not drawn up. And so I was trying to use all my might to just I could hear a little bit of air movement, and I was trying all my might to keep that positive pressure so I wouldn't lose some air exchange. And it was difficult. And again, I was like all hands on deck. I had to look at the PA. I said, grab that syringe, open that vial, drop 1 ml, and then push it. And they did. I probably said it in a forceful way. Like I said, Lisa, grab that, drop 1 ml and give it to the patient right now. And so they did. And the patient broke it and it was fine. Okay. And then we reintubated, and then all this took place within like a minute. And by the time I had broken the spasm, at that point I had more help to the room. But for that, 60 seconds, I don't know, 90 seconds, however long it was, I was the only anesthesia provider in the room at that time. So I'm telling you that not to scare you, but to just let you know that that's how quickly things can kind of unfold and how quickly you might need to grab that medication. Okay. Obviously I tried positive pressure. It was not working. The patient was not breaking. I had gas on. Again, the patient was, it wasn't breaking. So I was like, I'm just going to go ahead and go sucks. And I think this was a 16 or 17-year-old, boy. So he was very muscular. So like I said, the more muscular they are, typically the harder it is to break a laryngospasm. So something to keep in mind. let's talk about some other things that can happen during emergence. Obviously, sometimes they can go from 0 to 100. Sometimes it stinks when that happens, when you're like, oh, they look beautiful. And then like a second later, they're like, rah! Ready to knock your face off. And you're like, whoa, I didn't anticipate that. And so obviously you want to try to avoid that, but I'm telling you, anesthesia is different for every single person. And you sometimes you do the best you can and you think that they look comfortable. And just like during the case, you think they're okay. And then they hit something that hurts extra bad. And next thing you know, they're moving. And you're like, they were coasting this entire case, train track vitals. Now all of a sudden one additional thing, and now they're, jumping off the bed. So it can, same with wake up. Sometimes you can have, anticipate how the patient's going to do. Other times you're like, I didn't see that coming. And that stings. And so again, having propofol, I told my students, I call it my oh shit stick, because it really can help you and save you in a bind with whether it's a spasm, whether it's the patient's moving, whether they're waking up crazy. Propofol, you guys, it's a beautiful, beautiful drug. And you just slug them with a little bit of propofol, enough to kind of like make them like a little more woozy. And then, then you're good. Obviously make sure their breathing is stable. It kind of stinks when they wake up like that, because it doesn't give you much time to assess how they look, whether it's, obviously if they're arousable enough to jump off the bed, but you still don't know if they're, are they going to swing on their own if you slug them with propofol? You don't know, maybe they're still a little weak. They just had that quick knee-jerk reaction to like, fight or flight response, but you still have to watch them very closely, especially if you've slugged them with propofol, to make sure that they're maintaining their open airway and their oxygenation. Okay. And at that point, that's when you can throw a little bit of oxygen on the patient, take them over the PACU, and explain that you had to hit them with a little propofol at the end because they woke up and almost ripped out their IV. So that's one of the other things that can happen during wake up, is sometimes that people can wake up like really quickly and like violently. Probably it always seems to be 30 to 40-year-old males, for whatever reason, tend to wake up like with this emergence delirium. Kids are also very prone to that. Anyone who maybe has like some PTSD in their history, where they maybe, I don't know if they've had something in their history that makes you think, well, maybe there's some abuse involved, like maybe they have that in their history. Those tend to be people who, like, think about it, like when you're under anesthesia, it's kind of like being drunk, you're uninhibited. And you're going to lash out. And so that's kind of how I try to think of it, as far as trying to pre-plan whether these people are at risk for waking up with delirium. But sometimes they just do. Sometimes people just wake up with delirium, some don't. Sometimes, another thing too is having to pee. If you have an old male who wakes up and was crawling out of his skin, it's probably because he has to pee. So keep that in mind, especially when you're giving tons of fluids during the case and they don't have a Foley. That's going to be super uncomfortable to wake up with a full bladder. And that can actually cause some emergence delirium, because they're going to be like, oh, why does this feel so uncomfortable? My bladder. Like, I know me, when I have to pee, it doesn't feel good. So keep that in mind too. There's been times where like literally like we rescue people with a urinal in the OR because they have to pee so bad. It's harder for a female. I feel kind of worse for females, because it's not as easy to get them on a bedpan, but yeah, just keep that in mind, that sometimes patients wake up and they have to pee, and that might be causing some agitation. Okay, what else? So we've addressed some of the more common ones, I would say, with emergence, but the other one, let's talk about some pain medication. Like I said, that can kind of hose you a little bit, whether you gave too much or too little. Both are actually bad. Gave too little, well, now you're gonna have a screaming, crying patient who is, again, agitated, crawling out of their skin. If you gave too much, well, they're not going to get extubated. They're not going to breathe. They're just going to be sitting there building up their end-tidal CO2. And you're like, boop, boop, wake up. And they're like, no, I'm too comfortable. This is really nice. Thanks, Jenny. So keep that in mind too, that you want to try to optimize a respiratory rate. So that's why, like say at the beginning of the case, you give fentanyl and then you want to work in a little bit of Dilaudid. Now there's a couple different thoughts between how you dose your pain medication. Some people just start straight with Dilaudid and just use that the entire case, meaning you actually use it for induction. And then during the case, some people will give like maybe like just a little bit of fentanyl with induction and then switch to Dilaudid, and then not really give a little bit during the case. And then at the end, working more once you get them back breathing. The key with giving more longer acting pain medicine, and even fentanyl can burn you, but it tends to be a little more forgiving, like especially if you're working in a bunch of it over a period of time, but is just titrate to the respiration rate. Okay. And so that's really key at the end of the case. You don't really want to be slamming 1 milligram Dilaudid on your way over to recovery, because then we don't know, first of all, if they're going to tolerate that. So really, ideally, you want to be working that in prior to actually extubating, and then just give a little bit as you go over to PACU, or once you get there, put them on the monitor if they're still having pain and they're on the monitors, their saturation's okay, go ahead and give some more. Okay. Unfortunately, there are going to be times where you just can't take away someone's pain. And I know as an anesthesia provider, that's not a fun thing to experience. You want to make everyone happy and comfortable, but I'm telling you right now, it's not always going to be possible. And because they have to breathe. And that's utmost importance, ABCs, airway, breathing, circulation. So pain is not in that algorithm. So while you don't want them breathing 50 times a minute and that kind of thing. But, if they're saying they have pain and yet they're dozing off and desatting on you, or, if they're saying they're crying, but their O2 stats like 86%, like you have to, that's also back to why you need to optimize and for extubation as far as, are they weak from paralytic? Make sure that their respiratory rate is optimized. So you can work in pain medicine, but you have to always know that there are going to be some people who, no matter what you do, you feel like you can't control their pain. Unfortunately, that's when a regional anesthesia is a beautiful thing. When the surgeons localize, it's a beautiful thing. There's limitations to IV drugs. Okay. There's a lot more studies these days compared to when I first started 7 years ago to multimodal pain control. And it's really key, in my opinion, to having a really successful surgery is to take multiple approaches to controlling someone's pain. And a lot of times it starts with preemptively. Okay. Like if you have someone who's already on a fentanyl patch, for example, give a little ketamine with induction. Okay. And maybe a little ketamine with wake up. Again, hitting different receptor sites, different pain receptor sites. You have your mu receptor sites, your delta, your kappa, your MDA receptors. Really, the more receptors you kind of hit, your COX inhibitors, like the NSAIDs, that kind of thing, the more receptor sites you hit, the better control you're going to have overall. That's why gabapentin is commonly used in pre-op now to kind of control the neuropathic pain pathway. So again, the more multimodal meds you can give, the better. So IV Tylenol is great. Toradol, if you're able to give it. Again, if someone's high risk, maybe a little bit of ketamine along with some fentanyl and Dilaudid, just trying your best. And obviously if you can do a region, if they can localize this incision site or use any kind of regional, that's by far the best, because narcotics cause complications. Narcotics cause atelectasis, meaning if you really over narcotize someone in recovery, they're not going to breathe as deep. Okay. They're going to be breathing shallow. Okay. And so you're going to potentially cause a pneumonia, or you're going to maybe cause an ileus, because now you're going to slow GI motility down with IV narcotics. And now what if you have an ileus a few days after your surgery? And so again, just kind of always think that what you do is not benign. Everything has a complication to it, or a side effect, not even a complication, but a side effect. And so you want to make sure you're always thinking about that every drug you give, could be something that could happen. So I encourage you to kind of take that approach when you're dosing your medications of any kind, really. So we've kind of talked about narcotic again, and don't be afraid, you guys, to use Narcan. Not that you want to make that your ultimate goal is a Narcan, everyone, by all means, please. It's I remember, trust me, I've had a Narcan a few of my patients. Luckily, it doesn't happen often. But when you do, you kick yourself because it makes you feel like a failure. At least that's kind of how I feel. So I'm like, damn, why? I thought I was doing so good and then I overdid it. And so again, sometimes you have to learn the hard way. And it's okay. It's okay. Mistakes, you make a mistake. You obviously you can't just be like, well, they'll be okay. I'll just extubate them breathing 3 times a minute. No, you need to make up for your mistake, and you need to give them some Narcan. Make sure that they're safe for the PACU you nurse. You do not want to leave a patient breathing 3 times a minute, climbing their end-tidal CO2. That's pouring acid on the heart. And yes, a young, healthy person could probably maintain, but what if you brought a renal failure patient over there, or a patient who has an AV fistula, and now they're breathing 4 times a minute and you're dumping acid on already an acidotic person to begin with, because they already have underlying physiology as such. Well, now you're looking at potentially causing the patient to have some kind of arrhythmia and code. So yeah, it could be a really bad thing. Obviously the younger and healthier you are, the more you can tolerate acidosis, but that's not what you should strive to do. So don't be afraid to use Narcan. But I will say about Narcan is making sure you're not just slamming it in. This is something that, like, when I worked in the medical ICU, when we would grab Narcan, I don't know. Obviously I lack this training as an ICU nurse, but I used to just think 0.4 was you just push 0.4 milligrams. And it wasn't until anesthesia school that I was like, oh my God, we were pushing Narcan like it was nothing to these critically sick patients who were maybe over narcotized on the floor. We would occasionally run Narcan drips as well, but keep in mind when you're pushing 0.4 or Narcan, you're taking away all of their pain control. You're just completely reversing them. And it's actually a sympathetic stimulant. You're going to be putting them into potentially pulmonary flash pulmonary edema, because think about it. They're going to be like, they're going to go and take a giant breath in, because now you have just completely went from like 0 to 100 in a second. Not good for the patient's physiological process, body, nothing. So work it in slowly, be nice, give it just 40 mics at a time. Okay. So you want to dilute it down to it. Like if you have 0.4, dilute it down to a 10 cc syringe. So you have 40 mics per ml. Just give a little bit at a time. You can always take the syringe over with you, clearly labeled, and give it to the PACU nurse. And typically, you know, that the patients can re-narcotize in about 40 minutes. Okay. So you want to say, hey, the last dose of Narcan was at this time. And so they know that to watch the clock. So when it hits that 40-minute mark, to make sure that if they have to give more, they give more Narcan. Okay. But you really don't want to take away everyone's pain, all the pain control the patient has. You just want them to breathe safely, you know, and normal respiratory rate. And believe it or not, it doesn't usually take much. Okay. I want to say the most Narcan I've ever given was like maybe, I mean, typically it's like 80 mics, you know, maybe 120 mics, but I think I've gotten close to 0.4, but I've never ever even given 0.4 before to anyone who needed some kind of reversal at the end of the case for overdoing it on the Dilaudid or whatever method that I use to sedate the person with opioids. So yeah, so that's just a little tip there. But I think I kind of covered some of the biggest things, and we'll just quickly touch on PACU and kind of some things to expect, or maybe an ICU transport, especially if you're a new student, especially if you have a bigger case, and really should be for any big case. Make sure you're at the end of the case, you're documenting like how much blood you gave, when's the last time you dosed antibiotics, how much fluid they get, you know, those types of things. You want to make sure everything you did, how much Dilaudid they got, how much fentanyl they got, Versed, any of that stuff, were, you know, just make sure you're documenting what all you gave. So when you're giving handoff, you can tell them those key things. As far as like history of the patient, make sure you're keeping it pertinent. Nowadays, nurses usually have computers, so they can easily look up the patient before they get there and look up the full medical history. But no one really cares if your patient has impotence, okay? Unless it plays into maybe what they're having done in that procedure. But again, like, or eczema, like, I mean, if it doesn't pertain to like what is going on with the patient, like really key things like their cardiac, maybe if they have any drug allergies, maybe they're asthmatics, you know, you want to be making sure you're hitting key areas and not telling every single detail of their history, because you really want to get straight into the point, because it should be a quick handoff, and just making sure you're keeping it relevant to the case, relevant to any kind of safety or health concerns that you have, that the PACU nurse herself or himself would be managing, like the respiratory, the pain control, if they have cardiac issues, neuro issues, you know what I mean? Like, just keep it to the major systems. You don't have to say like, you know, they had a mole removed in 2016, that was a dysplastic mole, and they, you know, you don't have to tell them everything. Just keep it pertinent. And to help you, just make sure you're writing things down. Take a blank piece of paper with you, notepad, whatever. Obviously, respect HIPAA. Don't put any patient identifiers in that notepad, but to write down how much blood they got, how much fluid they got, EBL, urine output, when's the last time they got antibiotics, all that stuff is totally okay and to be expected, really. So that's my tip for a PACU report. You want to do your PACU nurse right. Make sure you're not bringing them over an empty bag of fluid. Make sure you're taking them over as comfortable as possible, and be prepared to treat them in the PACU. Meaning, okay, what if they look good because you kind of pulled the tube and they were still a little stunned from the gas, but now en route to the PACU, they're like rolling all over the bed, and you're like, oh, great. You know, bring some emergency meds with you. Bring some fentanyl, bring some Dilaudid, be nice. Because again, they can give pain medicine, but they usually take some 10, 15 minutes to get them checked in, that you check orders. It's not as easy for them to just whip out of their pocket and push drugs like it is for us. Same thing that goes with like blood pressure instability. Never, 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 ever leave your PACU nurse in a bad bind with blood pressure. You really need to be making sure that patient is not only breathing safe and is comfortable, but their blood pressure and vital signs are completely stable. Whether that means bringing esmolol with you, labetalol, you just think about it. You need to make sure that, you know, they're going to be in a good position to take over handoff from you and not have to scramble to like stabilize the patient. So you need to be bringing those types of drugs with you if you anticipate them needing it. Of course, like maybe during the case you had to give labetal, well, we'll bring some with you just in case you need some in recovery. Okay. Same with like fentanyl or Dilaudid or Neo or ephedrine. You really want to try to be optimizing. Do they need more fluid? Why am I giving so much ephedrine? The case is almost over. Like I need to figure this out. You can't just bring them over and expect them to push ephedrine. You really have to try to be getting down to why are they hypotensive? Okay. So those are types of things to think about when you're going through your emergence as well. Are they going to be at baseline once we get the gas off and are, breathing? And I think I touched on that briefly in the beginning, how you can't just take them over on a neo drip. So start thinking about that when you're getting close to the end of the case. Well, first, why are they on a neo drip? What has made them need that drip from the beginning? And how can I remove that drip? Do they need more fluid, albumin, blood? Are they too deep with anesthetic? Were the surgeons causing that? Like maybe there were some fluid shifts going on that they needed that extra little bit of help, but now that's over and you can wean it off. Just always try to get them back to their baseline. Like that's always the goal, is to get them back to their baseline prior to actually taking them over to any kind of recovery, even if it's the ICU. Now, don't get me wrong. If they need a levofed drip or neo drip or any kind of drip, that's totally fine. Okay. And to be expected, but you still want to try to optimize them. You don't just want to let, let's just say like they're on a Clevaprex drip, but you're like, oh, they're fine, they're stable. But now you get them over the ICU and they're like 80 over 50. Well, that's not stable. That's not optimized. And you should have been the one titrating that drip down, even if it's en route to the ICU. Meaning it isn't just because the case is over, your care does not stop until after you've given report to the ICU nurse, the PACU nurse. You have to make sure during that entire time that you're still making sure the patient is stable and ideal for the nurses you're giving report to. And one thing to make note of too, because I did open heart for a while, is circle back around. Like, okay, so you drop off open heart, fresh open heart, and look, they look good for you. You give report, you tell them all this stuff, yada, yada. Then go out, chart, come back and say, are you okay? Are you comfortable? Because most of the time they are, but every now and then you walk away and then like stuff starts happening and you again have drugs that you can quickly intervene and help, where they have to go get drips, string up drips, prime the pump, it just takes them too much time, where you're like, boom, some neo, boom, some ephedrine, boom, I'll just slam in. I mean, they can give albumin and stuff like that, but you have drugs. And so make sure you're circling back around as a courtesy check to make sure that the ICU nurse is okay after you've done your charting. And that's when you're officially done. But you always want to do that last double check. It's just a nice courteous thing to do. I wouldn't say you have to do it in PACU. However, let's just say you drop off a patient in PACU and they're like, kind of not really looking so good, but you stay around, you stabilize them, you help them, you make sure the PACU nurse has what they need to help the patient. You tell your attending, whoever's going to be following up with them. That's another thing too, is if you drop off a patient in PACU, you guys, and something goes awry or you're concerned of any kind, make sure you're not only communicating with the surgeon, make sure you're communicating with your attending as well, or whoever you're working with as your anesthetic team, who's going to be seeing the patient in recovery, because they need to know what's going on. And so don't just let the PACU, be the one to go and tell them, make a phone call, go physically find them, however it is you do your communication. You want to make sure you're passing off handoff to your anesthetic team as well, because they're going to be walking into it being like, well, I don't know what happened. Where's the CRNA? She didn't tell me any of this stuff. So you don't want that, so make sure if there's anything that you're concerned about, that you are circling, doing the full chain of communication and communication essentially, and making sure the right people know about what's going on. So that's kind of my gist, my story with Emergence. For those of you guys who haven't purchased your conference ticket yet, we are having a virtual conference. So you still have time. What is it? This is going to air, I think, a couple days on the 21st, I think, of October. I could be wrong, but I know it's going to be before the event. The event happens on the 23rd and 24th of October. It's a virtual event. You can go ahead and purchase your ticket now. Again, you still have time. We hope to see you there. We're going to cover all kinds of amazing things. We're going to talk about ICU pharmacology. I know that could seem intimidating, but even if you're a nursing student, it never hurts to learn information more than once. The more you hear it, the more you learn it, the more it's going to stick later on. And so we're going to cover that. We're going to cover how to deal with stress as a student. And heck, this is going to correlate for your time in nursing school, ICU. It's just stress management. It's going to carry with you throughout your time, both as a pre-anesthesia student and an anesthesia student. I'm going to talk about growth mindset and why it's so important to keep your mindset right while you're in school. school and how this is really going to propel your success. Okay, we're going to cover the best study tips that I can give you to help you not only where you are now, whether you're a nursing student, ICU nurse, taking some prereqs, and your time as an anesthesia student. I'm going to share study tips. We're going to break down the application process. What are some key areas and what to know about those key areas? We're going to talk about finances from a financial expert, not just me talking about my finances, my Amazon shopping, that is. We're actually going to have Natalie Kretzer, who's a financial planner, bring to you the best information that she can on how to pay for grad school. Okay. We're also going to be doing a Q&A session with current SRNAs. We're going to have a simulated mock interview experience, and we're going to have program director session, South College, Emory, the University of South Carolina. They're all going to be speaking at this conference. And so I really hope that you guys make time to attend. You're going to get FaceTime with them through little intimate rooms that are going to be like pop-off rooms. We're using a platform called Hopin, and it allows little breakout rooms or little virtual rooms that will just be you and the program director face-to-face talking. So that way you can still get that FaceTime. We're going to have a virtual photo booth, which I'm super excited about because 10 students in one virtual room, you can like put, a stethoscope on, you can hold a laryngoscope blade, put hats. It's going to be right around Halloween. So we might have a few Halloween themed rooms, but you can design your backdrop in your room, get your picture, print it out, have a memory. It could be a really fun way to kind of start your journey to CRNA. We're also sending you door prizes. We're doing raffles. We're doing giveaways for participation. We're going to be sending out people gifts. Again, we're not doing this in person, which we are sad about, but we're trying our best to still spoil you virtually by actually sending you physical gifts in the mail. So I really hope that you guys check it out. It's going to be a super fun event. Again, October 23rd and 24th via virtual. But I hope you guys enjoyed this episode, and we'll see you next week. All right, take care.